This conference will now be recorded.
Good morning, all of you. I hope you remember the class previously taken like a month ago or 2 months ago, where we are talking about the introduction to diabetes. We are done with that, and I think you remember. And I'm going ahead with the topic, like with the complications of diabetes mellitus. First, if I just know a statement like what do you call, what is the values of sugars, where you call it as diabetes, and I will proceed with the following topic, that is complications. What is the minimum value of sugar for a normal person? What are the values for a diabetic person? What is the FBS and PPS value in a diabetic person in and around, or what is it more than like? Any answer in the chat box? I'll proceed with the next topic. Hmm? Any answers? You just write both FBS and PPS. Greater than 126 of what? What is FBS? What is PPS? What is the normal value? What is the diabetes value? What is like the cutoff values are around it? Any answers? This I clearly mentioned that day. FBS greater than 126, RBS greater than 200. Any idea about HbA1c? Greater than 5.6. Which book are you referring to? 5.6 is how much of sugars? It's very less of sugars when you compare with that of RBS. More than 6.5. Good. So, like, what are the normal levels? As you told, you think like less than 126 is normal. FBS, you say, or what is the normal level of FBS? Normal level of FBS is 80 to 110, 70 to 110 you kept, but it was 110 previously. Now it is 100 only. But it doesn't mean that beyond 100 and 110 it is diabetes. No, it's not like that. But the value has been changed from 110 to 100. And what about the RBS in a normal person? Just wait, you stop telling present in between. You can give it at the end. Yeah, very good. It is less than 140. Okay. So if you remember this, I will. So when you remember the values, it says like that normal values in diabetics are different. So you need to know what can you do to treat the patient. Before treatment of the patient, I would just try to emphasize on the complications so that you know why is it like important to treat diabetes. Okay. The complications of diabetes are both acute and chronic. What are the acute complications? Acute complications are hyperglycemia. Sorry for the mistake. It's hyperglycemia, diabetic ketoacidosis, and hyperglycemic hyperosmotic non-ketotic coma. In the acute, there can be hypoglycemia whenever the patient is on medication, which is over the dose, then they can present with hypoglycemia. But usually the acute complication, either it might be because of the hyperglycemia disease per se. Hypoglycemia is with the treatment, not with the disease. You can't see the PowerPoint. 1 minute. Are you not able to see the PowerPoint?
No, ma'am.
Yeah?
No, ma'am.
No. Excuse me. PowerPoint కనపట్లేదంట.
కనిపిస్తుందండి.
కనిపిస్తుంది.
Yeah. So the acute complications of diabetes are hyperglycemia, diabetic ketoacidosis, and hyperglycemic hyperosmolar non-ketotic coma (HONC). So chronic complications are either broadly divided into two categories, either microvascular or microvascular complication. Macrovascular is that dealing with the vessels of heart, coronary artery disease, cerebrovascular disease, and peripheral vascular disease. And microvascular are retinopathy, neuropathy, and nephropathy. And non-vascular symptoms are gastrointestinal symptoms like gastroparesis, diarrhea, constipation. Genitourinary like uropathy, sexual dysfunction, dermatological problems, and infections. So broadly, there are three varieties of complications because of diabetes. Why is the complications of diabetes setting in? Any idea? What is this pathway? If you remember this pathway, are you able to follow this pathway? Did you remember something from your biochemistry? This is all the pathway which you might have seen from, yeah, which you might have seen from the biochemistry. See, whenever the diabetes is nothing but your sugar levels are increasing because sugar is not going inside the cell for its utilization for energy. So what is happening inside the blood or in the blood before it enters into the cell, the sugar levels are increasing. Whenever glucose is increased, sugar is nothing but glucose. When glucose is increasing, G6 glucose 6 phosphate is increasing, which is converted into fructose 6 phosphate. All these channels are increasing. When these increased, glucosidaldehyde 3 phosphate is increasing, and further all this because the glucose levels they are increasing. Whenever this is increasing, the other pathways related to it are increased or like converted more and more because there is more amount of glucose, it is converted to more amount of sorbitol and fructose. Whenever that is happening, what is happening to the energy? NADPH is converted into NADP, and that is like the energy inside the cell is not utilized because of the wastage, or is it's going into its inactive form or like in an ionic form. NADPH is converted into NADP. Here also NAD plus is converted into NADH. This is the polyol pathway. And the next one is fructose 6 phosphate, which is converted into glucosamine 6 phosphate, UDP gluconide glucoside enzyme. This and all are increasing. That is hexosamine pathway, polyol pathway, hexosamine pathway, and protein kinase C pathway. These all are increased because of higher levels of glucose and its substrate or like its broken products or like further products. All these are increased in case of diabetes because of higher sugar levels. So whenever there is hyperglycemia, that is glucose is increased in the body, which is converted by aldose reductase into sorbitol. Sorbitol decreases sorbitol decreases myoinositol, which is nothing but a nerve growth factor, which is decreased, and thereby it can cause diabetic neuropathy. Okay, and also this NADPH can be decreased because of its utilization in this particular pathway. When that is not there, there is decreased nitric oxide synthetase in the body or in the blood vessel. Whenever that is decreased, blood flow is decreased, and there is no particular vessel wall relaxation. Because of that, narrowing can occur and can lead to ischemic damage, which can lead to axonal loss or demyelination. Okay, this was something related to diabetic neuropathy. And hyperglycemia can lead to AGE precursors, protein kinase C, and hexosamine pathway stimulation, which all can predispose to oxidative stress. So now coming to hypoglycemia. What is hypoglycemia? Blood sugars levels less than 70. It's like not a single value of sugar is considered hypoglycemia, but the symptoms when it starts, or like what are the manifestations according to the blood sugar levels, those are taken into consideration. The causes are not per se diabetes, but because of excess use of insulin or OHA, that is treatment related complication. If a meal is skipped, and if you take a medication, there can be decrease in the glucose levels. And overexertion stress can lead to excess utilization of the energy whatever left, and it can lead to hypoglycemia. And eating late, unplanned exercises, all can happen in relation to it. Signs and symptoms. The signs are mild symptoms are diaphoresis. Uh, Whenever the hypoglycemia occurs, there can be diaphoresis, paresthesias, and moderate confusion and behavioral changes. And also there can be palpitations, tremor, anxiety. Initial, whatever they have is autonomic symptoms like diaphoresis, paresthesia, palpitation, tremor, anxiety. Moderate is confusion and behavioral changes, and severe are seizures, loss of consciousness, and shallow respiration and death can occur. What is the level at which these occur is something I'm asking you. You can put it in the chat box. So immediately whenever there is you think that is hypoglycemia occurred in a patient because of whatever the symptoms we discussed, then very good, less than 40 neuroglycopenia it is called as. So whenever that happens, what is the thing you do? You give the sugars, that is nothing but the glucose. You can just give the common sugar which we have in our house. And then next, coming to the other complication, that is HHNS and DK. Hyperglycemic hyperosmolar non-ketotic coma versus DK. What is the difference between the two? Yeah, plasma glucose is usually higher, like beyond 600 in case of honk, whereas in case of DKA, it is just more than 250. And if you see the arterial pH levels, which is more than 7.3 in case of honk, whereas in DKA, it is 7.25 to less than 7, or like in between, or less than 7.25, which means that it is more acidic. So it is diabetic ketoacidosis. Whereas honk, it's more than 7.3. It's not bringing down the pH very low. Either it's not like your plasma glucose is normal, it is also very high. And coming to the bicarbonate value, as acids are more in case of DKA, bicarbonate is also very less, like less than 10. It can be less than 10, it can be less than 10 to 15. Then in coming to honk, it is more than 50. That is a differentiation point between that of DKA and honk. And urine ketone levels and serum ketone levels are present in case of DKA. Whereas in honk, it might be present, might not be present, but that is not a criteria. But usually it is not present. Whereas coming to anion gap, in decay, it is more than 10, means that it is a high anion gap metabolic acidosis. Whereas honk, it is usually not higher, but it is less than 12. Um, Coming to what is the thing or mechanism behind the hyperglycemic hyperosmolar state and diabetic ketoacidosis. What is happening is whenever there is absolute insulin deficiency in the body, the glucose is not entering inside the particular cell. So when glucose is not available for the energy sources, what is happening? Cell is going to use lipids for its energy source. So what is happening? Lipolysis is increasing. Lipolysis, where does the fat come from? So what is, whenever the lipids are lysed more, what is happening? It is converted into free fatty acids. Whenever free fatty acids are present, they go to the liver and they are converted into ketones, or ketogenesis occur. So whenever ketogenesis or ketones are occurring, ketones are acidic. So what is happening to the levels are decreasing. So what is happening to acids? Acids are nothing but keto acids, as we told, they are increased. So overall, because of the insulin deficiency, you are having the ketoacidosis. That is one thing. So again, next point, whenever the free fatty acids are more, or like because of lipolysis, when they have increased and gone to the liver, they can be either triacylglycerol, which is nothing but hyperlipidemia. So the patient can have ketoacidosis, hyperlipidemia. And coming to the second point, these free fatty acids can contribute to gluconeogenesis because they can act as substrates for the glucose. So in the absolute insulin deficiency state, when the cell is going through all this mechanism, what is happening to the normal blood sugar levels? What are the blood sugars? Blood sugars are very high. Then what is happening? The counter regulatory mechanisms or hormones are acting. So whenever the counter regulatory hormones are acting in response to either hyperglycemia in blood, lipolysis, recording.
Screen share చేసిన PPT ఎక్కడి నుంచి స్టార్ట్ చేస్తారు వెబ్సైట్
దీని తర్వాత. Are you able to listen to me? Any
Yes, ma'am.
problem?
Yes, ma'am.
Yeah. Okay. So we were talking about this, right? So whenever this whenever there is insulin deficiency, there is going to be increased lipolysis and increased free fatty acids and ketones, which are nothing between but ketoacidones, acids, and triacylglycerol, which is increasing. Apart from this, what other things are happening is, as lipolysis is increased, protein synthesis is decreased, or like more of to say than the synthesis, you have to call like, as lipolysis is happening, similarly proteolysis is happening, because glucose is not entering the cell to give energy. So whatever the rest of the sources, the cell is going to utilize. So it is going to utilize lipids and proteins. So they are increasing. Whenever proteolysis is increasing, usually it forms or adds up to the gluconeogenesis substrates. As protein is in a state of catabolysis or like increasing in the form of proteolysis, the synthesis is decreased. So the gluconeogenesis substrates, they increase gluconeogenesis. And as the glucose neogenesis occurs, hyperglycemia occurs. From the other sources of non-glucose substrates, the sugar levels are going to increase in the cell again in the blood, and it can contribute to glycosuria apart from the normally existing sugar levels, which is high because of the deficiency of insulin. So glycosuria can occur, and also hyperglycemia occurs. Hyperglycemia, which leads to glycosuria, and glycosuria is nothing but increased osmolarity in the blood. Whenever the osmolarity is increased, what is happening? Osmotic diuresis occurs. Osmotic diuresis, it contributes to loss of water and electrolytes from the body, which can lead to dehydration. That's the reason patient with DKA HHS present with dehydration. Why is it dehydration very bad? Dehydration can lead to several other factors that can lead to hyperosmolarity. Whenever the hyperosmolarity occurs, and apart from the hyperosmolarity, there can be impaired renal function also. Impaired renal function can further contribute to the above mechanisms of hyperglycemia. So hyperosmolarity finally contributes to either HHS or TKA. So these two, apart from this, there can also be see, this absolute insulin deficiency is more of in case of type 1 diabetics. So what is happening? That is in case of diabetic ketoacidosis, which you see in the diabetes, but there can be overlap, but usually in case of DKA. And the other counter-regulated mechanism part about the ketones or about the protein and proteolysis, that is more of seen in the other part, that is hyperglycemic hyperosmolar states. So that can contribute, that can lead to the other side of the picture. So what is the treatment for DKA or HHS? Initially, as I told you, they are prone to dehydration or they are having severe dehydration. They can have, we should be treating their dehydration. The first thing you put for a patient or first line of treatment is IV fluids. After fluids only, either you want to give insulin or any electrolyte deficiency you want to correct, that should be done after IV fluids. Give them IV fluids and then followed by insulin, IV insulin. IV insulin as well as subcutaneous, you can give it at the same time, like 6 units IV and 6 units subcutaneous, depending upon the weight of the patient or how much insulin dose you might require according to your assessment. This IV insulin can rapidly act, and you can put it in the form of continuous drip as per the requirement. Apart from fluid and insulin, you need to take control over the electrolyte levels, which can be disturbed because of the ongoing process of higher osmolarity and dehydration. You need to replace the electrolytes, and there can be, there can be because of hyperosmolar state. There can be, that's the reason it was called previously as HONC, hyperosmolar non-ketotic coma. where ketones are not present like that of in diabetes, but it is hyperglycemic and hyperosmolar state which can contribute to the coma. Why is it happening? Dehydration can contribute to the, either directly it can lead to osmolarity difference and can cause the mental problems or coma, or obtundation regarding the uh, patient. So that can lead to the mental status can be declined, or GCS can be declined. For that, you need to check on the patient's mental status or GCS, and accordingly, that aggressively you need to treat the patients. You need to monitor for the input and output, because kidney shutdown is also common in these cases. And furthermore, you need to see for the central venous pressure monitoring as per the requirement, as per the blood pressure levels. And blood glucose monitoring is done every hourly to ensure that your correction of glucose in the drip form is not getting overcorrected or not getting undercorrected. And following it, and also you need to see ECG monitoring. The main purpose is because nothing electrolyte deficiencies or potassium abnormalities can present in the ECG, which can suggest if at all there can be any arrhythmias, and arrhythmias are also very common in this scenario. So ECG monitoring is very much required. And coming to cardiovascular and respiratory status, cardiovascular, as I told you, because of electrolyte abnormalities or per se because of the glucose levels, there can be arrhythmias which can be occurring. And respiratory status, cannot respiration, this acidosis is something when the acids are more, compensation of carbon dioxide is usually taking place. So you need to check whether the compensation is going on hand in hand, or is it having any problem with compensation where we need to intervene. Okay. Then following it, you need to, as we already discussed, which we give first one, the one which we give is insulin. Sorry, fluids. Fluids. What are the fluids of choice which you give to the patient? Usually it is NS, which you give 1 to 2 liters in the first time, depending on the patient and his dehydration status. And if you think the if you think the sodium levels are more or going to be higher, then you can go for the 0.45 half an hour or half an hour, where you give it at the rate of 2 to 5 ml per kg per hour. Or like when blood glucose levels less than 250, and you think like you don't want to add up to the osmolarity, you can give either half an hour or 5% dextrose solution. That is a fluid collection which you initially start. The patient comes, put them on NS, and just see for the sugars. NS is first or most important, followed by sugars. When the sugars are more, or like around 500, 600, you start the insulin treatment. How do you calculate the insulin dose? Usually it is zero point 0.1 units per kg bolus. For example, it is a 60 kg person, so 60 into zero point 0.1. So you give 60 units per kg per hour. Or if it is bolus, you give that also zero point 0.1 into 60 kgs. So it is 6. So 6 units you give IV, 6 units you give either a subcutaneous form, or 6 units ml per kg per hour drip you can give to the patient, which is a continuous IV drip. And if blood glucose does not decrease by 10% in the repeat, or like in the next step, you have to repeat the loading dose. That is nothing but 6 units per kg bolus. Repeat it again, and if there is no response, and then you double the infusion dose in the in the every 2 hours, or like till when the sugar levels are not responding, till then you keep doubling the insulin dose. For example, if it is 6, you try to double it in a set of 2 in the 2 hours. So next hour you can make it 8, and then you can make it 12. Like you can increase in a set of 2. And then that is insulin. Fluids followed by insulin. Then important thing is electrolytes. How do you want to do the electrolyte management? Is you check for the potassium levels. Is there any potassium deficit? You check it and give replacement according to it, and monitor for potassium levels also every at least 4th hourly, or depending on the case scenario where you need to do it. And then phosphate can also be low, and you have to replace when it is less than 1 milligram per deciliter. Then coming to the microvascular complications, there can be retinopathy, and individuals with diabetes mellitus are 25 times more likely to become blind. Severe vision loss is the primary result of progressive diabetic retinopathy and clinical significant macular edema, and it is classified as non-proliferative and proliferative types of retinopathy. In the picture, you can see this is a non-proliferative and this is proliferative. Hope you know this much better because you are in the optal where it is a very important question. In the first picture where it is not proliferating or like non-proliferative type, you can see little amount of hemorrhages. Usually you see the hard exudates and aneurysms also present. What is happening to the proliferative? Those aneurysms have ruptured and have formed, just not the hard exudate. Beyond it, there can be dot and blot hemorrhages, which is occupying the more amount of area. Usually, what you used to remember is when another diabetic patient comes, don't neglect the retinopathy, check the fundus if at all there is any retinopathy because you can prevent it in the earlier stages or like you can prevent the damage. Non-proliferative usually it occurs because loss of retinal pericyte and increased retinal vascular permeability and alteration in the retinal vascular blood flow and abnormal retinal microvasculature. These all can contribute to non-proliferative type. And appearance of neovascularization in response to retinal hypoxemia is the hallmark of proliferative diabetic retinopathy. These are formed near the optic nerve macula and may rupture easily and lead to vitreous hemorrhage, fibrosis, and retinal detachment. Duration of diabetes is one of the important key factor which determines the complication. Either it may be retinopathy or any other complications of neuropathy, cardiovascular abnormalities. These all are dependent upon the duration, followed by the degree of glycemic control in the population. What is the treatment you give? The treatment is prevention before the retinopathy sets in. How do you want to prevent it? You want to prevent it by giving adjusted or corrected dose according to the person's sugar levels or like keep the person's sugar in the target and have an effective glycemic blood pressure control which will delay or slow the progression of retinopathy. Known retinopathy cases, you can consider prophylactic laser photocoagulation. If it is proliferative retinopathy, can consider like pan-retinal laser photocoagulation. If there is macular edema, focal laser photocoagulation can be done. And you can have recently have more drugs in that area like anti-VEGF. You can use the ocular injection of bevacizumab, which is an anti-VEGF, that is anti-vascular endothelial growth factor inhibitor, which can be given, which can retard the progression. Coming to nephropathy. Nephropathy is a leading cause of CKD, which well understood because of the studies we have. It can lead to end-stage renal disease and CKD, which can require the renal replacement therapy, that is diabetes. After the onset of diabetes in the first years of life, glomerular hypertension, retinal hypertrophy occur, renal hypertrophy occurs, and which is associated with an increase in GFR. This one point I want to emphasize. If you see the picture, if you take a cross section of a healthy glomerulus, the first picture is something like you see the healthy glomerulus with a tuft of in the glomus capsule, and you see the urine or fluid passing by. In the second picture, if you see the blood vessels or glomerulus, they are thickened or the basement has got thickened. And also, why is it thickened? It is thickened because of the hyperglycemic levels, which can cause oxidative damage in the basement membrane, which can lead to formation of membrane, and that can contribute directly to the osmolar changes or differences in the membrane polarity, and which membrane polarity is the one which is holding without the protein leak from our body. In this case, when the basement membrane is damaged because of the osmolarity, the protein leakage is occurring. Whenever the protein leakage is occurring in the urine, what is happening? Proteinuria occurs. This is seen in case of diabetes. Okay, not like initially first when a patient comes, it's not that. It's like after certain period of time. In case of diabetics, there can be nephropathy. First, what occurs is glomerular hyperperfusion. That is the reason we have hyper polyuria. So you start at the initial levels itself, controlling the sugars. You can prevent all the complications, at least delay the complications. And renal hypertrophy can also occur. It is associated with increased. And then coming to diabetic nephropathy or kidney disease, this picture, what it demonstrates is, see, there is afferent and there is efferent arteriole. Usually the picture is the whenever for the more amount of fluid to rush down, there is constriction of the afferent and dilatation of the efferent, or like what is happening in this case of diabetes, there is constriction of efferent and there is dilatation, so more amount of thing is entering and there is more amount of hyperfiltration is occurring. Whenever there is hyperfiltration, proteinuria can occur. Then coming to the next one, hyperfunctional hyperfiltration is nothing but GFR more than 150 ml per minute, and normal usually it is less than 30. Whereas coming to the stage 2, next step, normoalbuminuria, which is also less than 30 milligram per day. In that case, when you compare with that of GFR, there is high. GFR is not usually high. If the blood sugars are not controlled. And then coming to the third stage, where there is incipient nephropathy or microalbuminemia, which means that the protein levels are between 30 to 300 per day. And overt nephropathy is like more than 300 milligrams per day. And stage renal disease also is more than 300 per day, but it is associated with decrease in eGFR also, where it is less than 15 ml per minute. It depends on the stage of CKD, where we are talking about the parameters. A stage of diabetic nephropathy, which is leading to chronic disease, chronic kidney disease, or end stage renal disease. Pathological classification, if you take into picture, there are 4 stages. The first one is mild or non-specific. Light microscopy changes and electron microscopy proven glomerular basement thickening. And if you see the inclusion criteria, it's like biopsy doesn't meet any of the criteria, which you will be telling later on. Glomerular basement membrane is more than 395 nanometers in female and more than 430 in that of male population, with an age of 9 years or elder. There is podocyte nephropathy. And coming to the second stage, there is mild mesangial expansion. Biopsy does not meet the criteria for class 3 or class 4, but there is mild expansion of more than 25% of the observed mesangium. Coming to class B, where is severe mesangial expansion. The mesangial expansion is more than 25% of the observed mesangium, but the biopsy does not meet the criteria of 3 and 4. What are the 3 and 4 criteria? There is 2A is nothing but mild expansion, 2B is severe expansion, mesangium, and 3 is the one of the at least biopsy doesn't meet the class 4. Plus there is one convincing evidence, like there is Kimmelston-Wilson's lesion, which I will show you later. What Kimmelston-Wilson, that is nothing but a nodular sclerosis, Kimmelston-Wilson's lesion, which is a specific kind of specific. And coming to the fourth stage, there is advanced diabetic glomerular sclerosis, and glomerular sclerosis in more than 50% of the glomeruli can be seen in the stage 4, and the lesions can be from 1 to 3, but the sclerosis level is more than 50%. Nephropathy in type 2 differ from that of type 1. How? Microalbuminuria or macroalbuminuria may be present with type 2 diabetes when they are diagnosed at school. Hypertension is usually common as they go hand in hand in elderly patients. Microalbuminuria is less predictive of nephropathy, likelihood of progression to macroalbuminuria. You can revert the microalbuminuria, but if there is macroalbuminuria, it means that there is something bigger happening. We need to take care of it. And coming to signs and symptoms, there is usually decreased renal output, edema, hypertension, proteinuria and albuminuria, and increased creatinine levels can be detected. This picture, it is a time course or development of diabetic nephropathy. Usually, if you take the time of onset, what is happening initially, GFR, which is of 120. First, there is in the first 0 to 3 months time, there is increase in GFR levels, or like there is going to be some hyperfiltration state where it is around 150. But the creatinine levels, because of hyperfiltration or more amount of urine or more amount of water, what is happening to the creatinine? It is getting diluted. So it is bit decreased in number, and later on further in the long run at a level of 10 years or 15 years there is going to be microalbuminuria. Microalbuminuria is 30 to 299 milligram in 24-hour urine specimen. Following it, after 15 years or beyond, there can be microalbuminuria, macroalbuminuria, which is more than 300 milligram per 24 hours. And also the GFR, then it starts to decline. As an example, it can be 120, 60, and then it can end up in a 25 year span of less than 10 or end stage renal disease. Creatinine levels can parallelly increase in that one. And screening for microalbuminuria should be performed in patients with type 1 diabetes for more than 5 years, in patients with type 2 diabetes, and during pregnancy. So because type 2 diabetes, when the patient present, they don't know since when they have type 2 diabetes, because they are after the complication they come in. So it's like required for you to check at the initial stages itself. Test for microalbuminuria spot collection. Exclude conditions that can transiently increase the albuminuria, and then repeat the microalbuminuria within 3 to 6 months period, and 2 of the 3 microalbuminuria test. If it comes positive, then you have to think in terms of albuminuria and you have to start the treatment. Non-diabetes related condition that can increase microalbuminuria, UTIs, hematuria, heart failure, febrile illness, and severe hypoglycemia and severe hypertension, vigorous exercises. So just check on it and then proceed. And then type 4 renal tubular acidosis can occur in case of diabetes per se. They may develop hyperkalemia, acidemia, which can be exacerbated by medications like AC inhibitors, ARBs, and spironolactone. And the treatment is like you have to improve the glycemic levels. Whatever the treatment, first is you have to control the sugars, and there should be strict blood pressure control, and and you need to administer AC or ARB depending on the requirement, and dyslipidemia also to be treated, because most of the diabetics are having such problems. Sulfonylurea and metformins are contraindicated in end-stage renal insufficiency. If AC inhibitors or ARBs are not effective, then go for calcium channel blocker, diuretics, or beta blockers. Renal transplantation is done with renal transplantation. You have to do whenever you do the transplantation. In case of end-stage renal disease, then you need to put on the chronic immune suppression for the patient for it to not react. There are so many problems associated with immune suppression, which can be dealt in the transplantation class. Neuropathy. Neuropathy occurs in 50% of the patients with long-standing diabetes, and it can manifest as polyneuropathy, mononeuropathy, and autonomic neuropathy. This picture, when you see the first picture, it is showing the healthy nerves, where there is intact blood vessels and there is intact vasa vasorum, which is supplying blood to the particular nerve. Coming to the peripheral neuropathy, what is happening? There is ischemia. Why is the ischemia happening? Because the vasovasorum is occluded. Whenever that is occluded, blood supply is not reaching the particular area. Why is it occluded? Because of higher sugar levels, osmolar differences, and also because of dyslipidemia. These can be blocked. Whenever it is happening, blood supply not going to the uh, particular nerve, and then when blood supply is not there, it's getting ischemia and getting damaged. That is damaged while latent nerve fiber can be present. Polyneuropathy or mononeuropathy can occur, and most common is distal symmetrical polyneuropathy, presents with distal sensory loss and pain. There can be sensation of tingling, numbness, sharpness, or burning that begins in the feet and spreads proximally. Diabetic polyradiculopathy is a syndrome characterized by severe disabling pain in the distribution of one or more nerve roots along with a motor weakness. There are self-limiting, it is self-limiting and can resolve in 6 to 12 months depending on how well you control the sugar levels. Monopathy. Dysfunction is associated with either cranial or peripheral nerves. The single nerve can be involved. Involvement of third cranial nerve is most common, and then can lead to diplopia, ptosis, and ophthalmoplegia. And if you see this picture, Usually, the patient can have peripheral neuropathy or like a tingling sensation of the feet, which can lead to trauma. And also, the trauma is not taken care of because the patient doesn't have sensation, and that can lead to bigger ulcers and can form diabetic ulcers. Autonomic neuropathy it can involve multiple systems like cardiovascular, which can lead to tachycardia, orthostatic hypotension, gastroparesis. There can be bladder emptying in sympathetic nervous bleeding, which can be hyperhidrosis of upper extremities and hydrosis of the lower extremities. Anhidrosis of feet can lead to drying of skin and cracking, which can lead to foot ulcers. So, whenever there is drying, try to use an emollient where the drying doesn't occur. It can reduce the counter-regulatory hormone release, and hypoglycemic awareness can be masked. It's a diagnostic test which you do for diabetic peripheral neuropathy. The autonomic test in patients with symptoms of autonomic neuropathy to evaluate the blood pressure in different positions and their ability to sweat. And electromyography, you do it to measure the electrical discharge in the muscle. Monofilament test is to determine the sensitivity to touch, and nerve conduction studies is to measure how quickly nerve in the upper and lower extremities conduct electric signals. Quantitative sensory testing to assess how nerves respond to vibration and changes in temperature. Treatment. Glycemic control is must and the most important one, and avoidance of neurotoxins, alcohol, smoking, and supplementation with vitamins like B12, folate can occur. Checking for the feed daily and taking precautions is more important because prevention is better than cure. And chronic painful neuropathy can respond to duloxetine and gabapentin. And GAT symptoms or GUT dysfunction can be like delayed gastric emptying or gastroparesis, anorexia, nausea, vomiting, early satiety. Altered bowel habits like constipation and diarrhea can be present. Cystopathy can be seen. Inability to sense a full bladder and failure to void completely. And there can be sexual dysfunction. Treatment. Small frequent meals that are easy to digest, low fat and fiber diet can be given in for gastroparesis and in cystopathy. You need to schedule the period of voiding and have to tell the patient that he has to void even before he get the time to fill the bladder and void by itself. And there can be self-catheterization and as required. And cardiovascular diseases can be in form of coronary artery disease, which is like MI, CHF, and the risk factors mostly for it is dyslipidemia and hypertension. In a patient with non-CHD, ACE inhibitor, statin, and aspirin can be given for the treatment because it helps in both the diabetes as well as heart disease. Lower extremity complications which can occur, foot ulcers, infections are the major source of morbidity due to neuropathy. There can be abnormal foot biomechanics and poor wound healing can be there. So disordered proprioception can be detected initially, and if it is there, you can advise the patient that he wears a soft chappals or like he takes care that there won't be any trauma for his lower extremities. And there can be abnormal weight bearing because you don't know where, how much time you are putting the weight on the particular site. And because of that abnormality, callus formation can occur, which can lead to hammer toes. If you see the first picture, it's a hammer toe. And then claw toes can be there because you don't know at how much time you are putting pressure on that area, which can lead to calluses and deformities of the joints too. And the right side picture is a charcut foot with a rocker bottom foot, where it is because of the similar, where you are not able to sense the pressure put on the particular area and the deformities are occurring. Charcot joint is present as an unexplained swelling and erythema of the foot. Profound sensory neuropathy can make this process painless, but it is very there is so much of damage inside to that particular bone tissue. Most common location is the tarsometatarsal articulations. Foot care for the patients with diabetic neuropathy is to be advised whenever the nerves are damaged. Foot care is very important because it can prevent from morbidity. First, usually clean the foot daily with a moisturizing lotion and perform daily foot examination, and always wear a soft chappals or a shoe where there are no sharp edges, and you have to daily check if at all there are any cuts, swelling and blisters. And the other common complications are infections like candida, pneumonia, urinary tract infection, lower tract infections, and pyelonephritis can occur. Dermatological are cirrhosis, pruritus can occur, and diabetic dermopathy like pigmented peritibial papillopathy, papules, and diabetic skin spot and can occur. Diabetes diabeticorum is one of the other entity where you can find all the bigger picture of the diabetic variants. Like acanthosis nigrosis can occur, and generalized localized granuloma annulare can be present, scleroderma, and lipoatrophy, lipohypertrophy can be seen. So these are the complications which are associated with diabetes in brief. This is at your level where you can understand. If at all any doubts, put in the chat box. Anything you just let me know in the other class. So I am ending the class. If anything, do let me know. Put the attendance now.